think, especially with the mechanism, think brain injury, okay? Think we are dealing with a TBI, okay? And we'll go over like treatments in a second. Posturing. You see posturing? Okay, and this gets hard. I've missed this once. I had a patient that, back in the days backboarding, they were backboarded and they went like this.
Oh.
And I thought it was seizure. And that was posturing. And I missed it. And I pushed for set on them. Which probably wasn't the worst thing in the world. Like, they stopped doing it, which is cool. And then they died. Eventually. I mean, not during my care, but they died eventually.
Would it have changed your treatment though?
No, not really. And I wasn't that far from a hospital. It would change my treatment. I probably wouldn't have pushed for set.
Oh, so
If I had seen that it was posturing, I probably would have thought more about, now I would think more about like a 3% or something like that. But at the time I didn't have it, okay.
3%.
So we'll go over treatments, but 3% is, so normal saline is 0.9 sodium sodium chloride, right? So 3% is 3% sodium chloride. So it's almost 3 times as much sodium in there. It's what's called a hypertonic solution. So it's got a lot of salt in there. So basically that salt gets close to like where that fluid is shifting, and it pulls that fluid into the bloodstream. And it's supposed to make the brain shrink is the idea. That way we change the Monroe-Kelly doctrine and give more land to Germany or whatever, however that works out.
Leave it thrown.
So you have changing level of consciousness. And this is like the probably the easiest one to pick up on, but that is probably a herniation syndrome with enough mechanism. Seizures, posturing, pupils. Those are the things you want to watch out for. Those are the things that we can assess, right? If you see any of these, start thinking like this patient is probably herniating, okay? Now, what makes the difference with these patients? Blood. Blood makes a big difference with these patients, okay? So there was a study called the EPIC TBI study that was actually pre-hospital for once, finally. Dan Spate out of Arizona, rural metro down there, they did a huge retroactive, big study. I want to say it was, I don't know, I just read it last night, I should remember, but I don't. It was a really big study, and basically what they found is there's 3 things that will help your patients survive TBIs. And the difference in the 2 is huge mortality-wise. So 1, as you guys can come up with, hypoxia. Why? You need oxygen, turns out. Your brain does too. Your brain needs what to survive? Oxygen and glucose. Your 8 pound of brain takes up 20% of your body's glucose. It is a glucose oxygen eating machine. That's what it does. Okay? So hypoxia. And where are we talking hypoxia? Well, this will depend on how hypothermic they are. If they are hypothermic, we need more oxygen on board. If you guys are tacking these patients out at like 99, 100 for our short amount of time that we're with these patients and they're hypothermic and we're warming them, you will not get nasty grams from your QA officer. And I can promise you that.
That guy.
This guy over here. Now, do we want to rack them at 100? Probably not, right? We want to reduce it down to like 97 to 99, hopefully. It's not how the real world works, but if we're talking about goals, that's our goal. We want to avoid hypoxia. Number 2, what do you guys think?
Hypotension.
Hypotension. Uh-oh. What did Dana just get done saying? Aren't we supposed to permit hypotension? Not in brain injuries. Brain injuries are different.
Yeah, you're staying at what, 90 systolic?
90 systolic, minimum. I would say you almost even want to shoot for 100 to have a little bit of a buffer.
Okay.
What map are you shooting at?
65 to 70.
Okay.
Yeah, we are trying to keep these patients at homeostasis. Now, what happens in a polytrauma when they're also bleeding out of their liver? That sucks for the liver.
Right.
We need a brain.
Mhm.
Okay, brain first. That's why we talked about this one
So-
first.
They'll be warm and bleeding out the liver.
Yeah. They'll know that they're bleeding out of their liver.
Right.
Rather that. If you had to ask anyone in here if you'd rather have a kidney or a brain, I want a brain. Yeah? Mm. So hypotension, and yeah, this is a map of 65, 70, or 90 to 100 systolic. And this is injury stuff. We'll talk about the guidelines a little bit later that have just changed a little bit. Number 3, you guys ready?
Tachycardia.
Go. A shock state.
Mhm.
Not in this trial, but that's a really good thought, right? Like if your shock index, which is defined as what? How do we get our shock index?
Pulse to pressure.
Yes. Pulse over systolic. Good job, Steve. If we get into that situation, we do need to give them something to either volume replacement or pressure replacement. But in this study, what was killing people?
Hypothermia.
This was in Arizona.
Extra hot hyperthermia.
No, really.
I was asking Kate for my hyperventilating.
Uh-oh. Guess what? Guess what we did for years?
Yeah.
We hyperventilated our patients on purpose.
End title of 30. End title of 30. That's
And
what
title
it's
at 20, 15.
Oh, wow.
Oh yeah, we did it all over the place. We thought we were saving
It's supposed to
lives.
be 30, 35, right?
Well, so when you hyperventilate somebody, we're blowing off CO, right? CO2.
Right.
The other thing we're doing is we're causing cerebral vasoconstriction when we do that. And that is a mechanism that's tied to itself, but we'll keep it simple. We'll say if we breathe too much on any patient, that's also important, any patient, traumas, arrests, whatever, you will cause a little bit of cerebral vasoconstriction. Now, if they need it, that's actually not that bad. But we were putting people into like alkalotic states by doing this, right? Well, problem is it turns out your brain needs blood and oxygen to stay alive, okay? So Dr. Humphreys had a really good talk about this. So there's zones of injury, right? We remember this?
The penumbra.
The penumbra. So in brains, we call this a little bit different. This is like the dead zone. This is where like the injury happened, you ain't getting it back, it's gone, I'm back. But this area around here is called the penumbra. And this is the area that can be saved. This is the area that's hypoperfused right now, but it's not gone yet. What does it need to stay alive?
Sugar and oxygen.
Sugar and some way to get it around.
Sugar
What about
and oxygen.
N-acetylcysteine for the glutamate? Because it releases, the brain cells release glutamate.
You know,
When they're injured.
in these situations, generally, Jeff, you're not, hypoglycemia generally isn't the issue. Usually your body has enough circulating
Not that,
glucose.
the glutamate. Because glutamate is, it's a neurotransmitter, but it's also neurotoxic at high levels. And when you have a brain injury, the cells release it.
Oh, that's true. I don't know, yeah. So even if you think about that though, like,
Not that we can give it, it's not our thing. but
Right.
it does, and
We just want to maybe just push fluids, try to just wash it.
yeah, you gotta remember the brain is only 8 pounds. So generally when it's perfused, you can get enough flow around it. Like we don't have a ton of like built up toxins compared to like metabolic toxins, byproducts of metabolism compared to other parts of our body. So maybe, yeah, could be. I don't know. I don't know if there's ever been any studies on it. Be a good.
I know they were pushing steroids
question.
for a while, and they found out that didn't do anything.
It didn't do anything.
Maybe,
Dang it,
Yeah.
so she also makes a good point in here. They have tried so many different drugs to try to get the brain wonder drug to work. Prostaglandin was one for a while. That didn't work. TXA was the most recent one. Didn't do great. It did okay.
So no benefit, but no adverse effects either, right?
There was a slight benefit.
And mild TBI.
So if you actually read the study, there was a slight benefit, but not crazy benefits. Not nowhere near what the polytrauma benefit of TXA was, but there was some. And it had to break down into different brain injuries, like mild, moderate, or severe. It did better, I think, in the moderate and mild than it did in the severe. And that makes sense because people with big brain injuries die. What do you want? So what the problem with this penumbra was is that we were hypoperfusing it on purpose. We were like, no blood for you. We don't want any more blood in that vault. So it wasn't getting any perfusion, and it was just dying and dying and dying, and this dead zone was getting bigger and bigger and bigger because of us. Oops. So their recommendation is same as my recommendation for you guys. Just keep it between the mayo and the mustard. 35, probably 40, maybe on the lower side. If you are going to do a hyperventilation treatment, what they recommended, what Dr. Humphries recommended, is figure out what their end tidal is before you intubate them, and then go 5 below that.
Oh, okay.
Right? We'll see.
For TBI.
For you guys, 35
Mhm.
all day long. Let's not get too fancy with this stuff, right? Like, this is not what is going to make the difference. Hyperventilating someone will not change the outcome for the better for us. That is not going to help, and it probably won't help your patient either. Okay, makes sense. So these are the things we are trying to desperately avoid, right? It happens. I can tell you, most patients that you have to intubate, it becomes very hard with hypoxia. Hypoxia is the one you're always trying to work on. Hypotension sometimes too. Sometimes it's hard to, they get low and you can't get them back up. Remember, we even in TBIs, that triad or diamond of death matters in this stuff. Would I push mic acid? Would I push calcium on a isolated TBI? Maybe. Probably has a little bit less benefit because there's such a small clot space generally compared to like a big aortic shear or something like that. So maybe. I'm not afraid of pushing calcium. It's cheap. It helps people. So.
But two says it's good for your bones.
It's good for your bones. Yeah. Yeah, maybe they'll get better bones. Another big thing with these guys is just make sure to manage the things that you guys can manage. Temperature, seizures. Make sure you don't let your patient seize. What happens when you seize? What do you deplete?
You're on. Well, you're.
Sugar. That's exactly right. You blow through all your sugar. Your entire body does a workout.
Yeah.
Right? Every muscle in your body gets a burn. And so you release acidosis, you also get glucose. So we want to treat these seizures, okay? Versed is probably the best one. Be aggressive with your Versed. 2.5 probably isn't going to do it on these patients. Probably going to need 5.
You guys are flowing Keppra on these guys now, right?
We will do Keppra en route. Another seizure prevention.
If you're looking at sugar, sorry.
No, it's okay.
Looking at sugar,
Ketamine too. Ketamine will help.
Is there any idea of like pushing thiamine, like treating people like a chronic alcoholic?
All I would say on that is just monitor the sugar. So if they seize, take another blood sugar. Make sure that it doesn't drop too low, and then treat it accordingly.
But we're not gonna try targeting the blood sugar in the brain stuff.
No, I wouldn't think so, because it's kind of a different mechanism than what thiamine will give us. No, just make sure that when they seize, they don't drop too low. We just don't want them to seize uncontrollably for a long time and be like, oh, it's okay. It's not okay. If you are at the point where you can't figure out if it's a posture or a seize, treat the seizure. Right? When they seize too, what's the other thing that they generally will do? Become hypoxic. So we just got to watch that as well.
Burn up a bunch of ATP and stuff.
That's it. You're burning everything. Whole body workout. You're getting a CrossFit workout in a minute.
They're going unconscious every time you see them. So they're losing their ability to fire the chemo receptors and all that good stuff.
Yep. So what else? What else can we do? What generally will we do with most TBI patients? There's a couple of BLS treatments that should get done on all of these patients. Stopping other bleeds, yeah.
Sit them up.
Sit them up.
Sit them up.
Sit them up. 30 degrees. You guys don't know how tall that is? It's a foot from the back of the gurney.
Yeah, well,
Foot.
No Trendelenburg, huh?
No,
Really? I'm just
no.
messing with you, yeah. That
Not
was
on
the other
this one.
thing.
Yeah.
Mass trousers.
Yeah, the
or
mass, yeah.
Trendelenburg.
Yeah.
Squeeze all the blood toward the brain.
We've
Yeah. Push the blood at the brain. It's
Yeah,
a good idea.
that's
Remember,
a good
because
idea.
on the code, not the code, but on our RSI, we're like, elevate the bed.
Yeah, so is that why they're doing heads-up CPR in different agencies?
That's exactly right.
Okay.
Exactly right.
Yeah.
Yep. And they're getting some benefit. We'll see if it's.
Sticks.
There's different. They're trying it with different mechanical devices. What they're finding is that the pressure that you can apply CPR might be too low because now you're pushing on
Oh,
the
even
chest
with like
like
a Lucas or
this.
something?
Well, the Lucas tends to like fall.
No, okay.
The Zoll is probably the best one for those. Just doing the inner thoracic squeeze.
Mhm.
We'll see. That trial is still active, I think,
Okay.
with the heads up CPR.
Keep them midline.
Keep them midline. That's the other thing.
So all the flowing keeps flowing.
On both sides. Remember, we have venous drainage on both sides. So if we're kinking one off, that's probably not good. And your airway, right? You're losing a little airway space. So just keep them midline, keep them breathing, keep them normal intensive, and don't hyperventilate them. Also, don't hypoventilate them, right? We don't want their end tidal climbing above 45.
Looking for neutral.
This is also acid, that becomes acidotic, right? Now we have a respiratory acidosis, so whoops. So we just want to keep them between the two, 35 to 45, right? We want to, eventually we'll have rock, we're gonna want to take those airways too. Those patients will deteriorate. And when they deteriorate, they seize, they get combative, they get all sorts of stuff. We want to control all of those factors. Also, ketamine can help prevent seizures.
Yes.
Oh, really?
It can.
What is it,
Yeah.
it's an NDMA?
Mm-hmm.
Is it an antagonist? Indian antagonist?
NDMA
So I'd have to look it up.
agonist?
I think it's an agonist.
It's an agonist because it's when you can't, when the Versed doesn't work, because you've got all of this neural firing, the ketamine will agonize that.
Yep.
And it will take over and you can give ketamine.
The other one that's
For
really
stress.
good for seizure control is propofol. We ran
Yeah.
it. But you can, if you get those three on board, it's pretty low likelihood that they'll then have a seizure after that. Also, we have Keppra at MedX. And that's a lot of the reason that we have it is we have long transports. After you guys drop off to a fixed wing or a helicopter, that's still a long time till you get that patient in. So if we start, for whatever reason, there's some sort of change in the paradigm and we start having to drive these patients all the way in, we will add those drugs here.
1 minute.
1 minute. Okay. Probably the lowest priority of all. Oh, the other one is reversing anticoagulants. Take these patients to the hospital, you find out that they're on heparin, make sure that they treat that. That becomes very, very important. That's how Mima and Grandpa die from these, is they're anticoagulant, they're on warfarin. We want to treat these warfarin specifically to an INR of 1.5. That becomes really, really important in these patients. It's just like any other trauma. We want to make sure.
Just try to get vitamin K on before we leave.
K or FFP. Usually FFP is faster. Let's see. And the last thing you want to think about is so if you run out of things to do, 3%, like we were talking